Do you want to click or do you want me to click?
If you can click. It's good.
We found out it's better when she does it.
Okay.
Whenever you're ready.
Okay, can we go to next? So, yeah, I have nothing to disclose. Okay, so the learning objectives of this is we try to always say like addiction is a neurobiological disease. So hopefully in the next 30 minutes we can talk a lot about neurobiology of addiction, and hopefully everybody can understand the neurobiological underpinnings of the chronic disease model of substance use disorder. And we're going to describe some basic neural circuits involved in substance use problem. And finally, we're going to talk a little bit about the rationale of combined medical pharmacological treatment and cognitive behavior treatment of the substance use disorder. Yeah, next, please. This is my references. So ASAM has a very wonderful the definition of addiction. So addiction nowadays is considered as a primary chronic disease of brain reward, motivation, memory, and related circuitry. So what it means is basically, yes, addiction is a disease. It's a primary disease, actually. A lot of times we say this patient is a primary psychiatric disease, then addiction, as a secondary disease, actually is wrong. Addiction is a primary psychiatric disorder as well, and it's a chronic disease. And also there's a pathological, findings in this neural circuitry in our brain. So dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. So it's like many other psychiatric disorders. So addiction as a disease, it also has biological, psychological, social, and spiritual components, manifestations. So that means my understanding of this second sentence is basically addiction is a psychiatric disease. It has biological, psychological, social issues. So it is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. So that means what is the pathology? Pathology here is basically this brain circuitry. Something's wrong with the brain circuitry, but in the meantime, the manifestation is patients. It's not like having blood sugar, which we can measure, but or blood pressure problem we can measure. We can have a number over there, but actually they have lost control. They just the only priority in their lives is drugs. So they're pathologically pursuing reward or relief. Okay, next, please. So this is a recent case I encountered. This is a real case. I just discharged her like a couple of days ago. This is a 34-year-old female, currently 12-week pregnant, smoking cocaine 8 ball a day. That's like, we're talking about 3.5 grams a day. That's a lot of cocaine. And she has lost custody of her 5 children and now is homeless. So I'm pretty sure everybody else has seen a similar case, right? Yes, next, please. So I always ask myself this question. The more I do this, the more patients I saw, I always ask myself the question, what is the closest connection or relationship any two human beings can have? I mean, everybody will agree it's mother and child, right? And then the second question is, what other disease can lead people to choose to continue to use something pathologically, okay, to get a relief or get a reward over having their children? So what is more important? And the third one is, who in their right mind would ever choose a substance over their child? So if we say addiction is a choice, then can you imagine any human being would choose addiction over their child, their children? Next, please. So maybe this experiment 60 years ago could explain why people choose drugs over their children. So it all started in lab experiments by Dr. James Oates. Actually, at that time he was a postdoc in McGill University. He did neuroscience research to try to find, at that time was focused on the reticular activating system. So they poked the brain, different areas, then finally, accidentally, one region of the brain, they put the electrode on there in that place and started stimulating. Then the rat, in this case, got overstimulated. And actually, then they give the rat only two choices, either food or just pressing the lever to be stimulated in this area. So then they found those rats, actually, they choose to just press the lever and totally ignore the food, which is kind of, they starve to death. Then they just, they prioritize very differently. So it's kind of amazing. Then this area of the brain is a pleasure center. It can give the rats this kind of gratification to the point they can totally ignore their needs, basic needs. We're talking about for survival. So next, please. So yes, their brain changes, their neurobiological changes. So over the years, a lot of studies have been done, and human subjects, animal studies. So for those people who were addicted to methamphetamine, they did the MRI. This is one of the first studies by Dr. Wexler. So basically, they found like the gray matter. The human brain is a very complicated organ, right? Human brain has about 86 billion neurons, nerve cells. So the gray matter basically is where the majority of nerve cell bodies located. So we're talking about this. You see this red, yellow area, and those areas are frontal cortex of the brain of this methamphetamine addicted person. So this reduced gray matter, actually from MRI, show like basically some neuron cells change happened over there. Maybe just it's a trophic change, or maybe just the number of cells got like reduced. The next, please. So another study, they compared the cocaine user and a healthy volunteer. So the two arrows point to the cingulate gyrus, basically is the brain area, which is kind of related to emotion regulation. Okay, so then they found that cocaine users, okay, when they watch the videotapes of drugs, cocaine, and the paraphernalias, and even like any objects kind of can remind them of their previous use, even if they did not report any cravings, and their brain activity is different. So you see the red yellowish area means overactivation. So you see the cocaine user, actually we're talking about this cingulate area is overactive. However, in other areas of the brain cortex is underactive. So that means maybe this kind of, the inhibition control is lost in these cocaine users. Okay. Then also for this cocaine markedly reduce dopamine D2 receptor availability. We know this pleasure center, the nucleus accumbens, mainly we're talking about the main neurotransmitter involved is dopamine. Then they found with chronic use, actually all these people who abuse different drugs, including cocaine, and the dopamine D2 receptors availability changed. That means the sensitivity to dopamine has changed. Next, please. This not only happens in cocaine users, it also happens in methamphetamine users and people who are addicted to alcohol and heroin and everything, all different kind of drugs. So basically, those D2 receptors are lower in people addicted to drugs, comparing with control. So nowadays we understand the pharmacological mechanism, how cocaine and amphetamine or different drugs can affect the dopamine activity. So cocaine, we know that it can just block the dopamine transporter protein, which recycles the dopamine back into the neuron cells. So basically, once you block the recycling, you increase the dopamine activity in synapses. That's how it works. Okay, next. So this is a wonderful graph. I think Dr. Herschler showed this graph also in last week's addiction seminar. So actually three areas are involved in addiction cycle. Actually, this picture depicts the whole, like this major three areas, and also associated with different phases of addiction. So we're talking about first the basal ganglia. Basal ganglia is related to the effect of reward, pleasure, and also the formation of habitual and routine use of substance abuse. And so when people started using or binge using, and basically this rewarding circuitry got activated. Then the second area is extended amygdala. Amygdala is an area which is kind of very much related to our emotion control, and it regulates the stress, the anxiety level, and which is very much related to this withdrawal symptoms, right? And also a negative effect. Finally, the prefrontal cortex. That's the area in charge of executive functioning. We're talking about planning, organizing, managing time, prioritizing, and all these kind of things. So these three areas are closely connected, coordinated in talking about this addiction cycle. Okay, let's go to the next slide. So again, addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. So that the previous graph kind of tells us, yes, three areas are involved in three phases of addiction cycle. Then what is the circuitry we're talking about here? The memory circuitry, motivation circuitry, reward circuitry. So what is circuitry look like? So I kind of redraw this picture. I thought about this, and then finally I came up with this circuitry. I tried to make a circuitry like a circuitry. So I drew four nodes here, and I kind of separated the nucleus accumbens, VTA. Actually, they're both in the basal ganglia area. If you compare this graph with the previous one, actually the prefrontal cortex is still the same area, which is in charge of executive functioning. And amygdala, I just extended a little bit because the previous graph and basically used the extended amygdala area, but I put like a hippocampus as well, because memorizing the drug use, the pleasure from the drug use is kind of very important. So it's amygdala and the hippocampus. Then the nucleus accumbens and the VTA, actually VTA is part of the midbrain, and this is where the dopamine neurons start. So I separated them so I can explain to you a little bit more in the next slides. Yes. So one way to conceptualize this, the addiction reward circuitry, is to divide them into two complementary parts. So the first one is reactive, bottom up. The second one is reflective, top down. So let me explain a little bit more in the next slides. So, okay. So remember, we're talking about three areas and four nodes. And the reactive part actually consists of three nodes: VTA, ventral tegmental area, nucleus accumbens, and amygdala, and the hippocampus. Okay, next slide, please. So this is how it works. So when we see any stimuli, okay, talking about which can give us a lot of pleasure, food, sex, drugs, cravings, cues, whatever. So it all starts from VTA, ventral tegmental area. The ventral tegmental area is, like I said, is where the neuron, the dopamine neurons start. So these neurons project to the nucleus accumbens. It causes, these neurons, when they're fired, they cause dopamine surge. It depends on what kind of drug, depends on what kind of stimulus it is. So what's important is the magnitude and the speed, the onset of the firing. So of course, drugs can cause many units of dopamine release comparing with food or sex. So some people say like a cocaine can cause, methamphetamine can cause like 10 to 50 times of dopamine surge in nucleus accumbens. But anyways, so when the reactive system, how reactive system work is, yes, so you see the stimulus, you see the drugs, you see the cues, then these neurons got to start firing. Then they cause dopamine surge in the nucleus accumbens. Then amygdala and the hippocampus, plays a role as well, because they can learn the pleasure. Because each time you have a dopamine surge, then amygdala kind of remembers that. Then the hippocampus consolidates the memory and stores the memory somewhere. Wow, using cocaine makes me so high. using benzodiazepines, really can calm me down. That's the only thing that worked, right? That kind of memory got stored somewhere in the brain. Then also, amygdala and hippocampus also, have another role, which is very important. It can detect the stimuli. Okay, the next time when remember the cocaine user when they're exposed to cocaine, paraphernalia, or whatever, so they can cause like the brain activity change. So this time, the amygdala and hippocampus started activating, and they also try to send a message to nucleus accumbens to tell the nucleus accumbens to have dopamine surge as well to take impulsive action. So I use red arrows here to represent basically those are dopamine neurons. These blue arrows are basically glutamate neurons. So this is talking about the neurotransmitter. There's a difference here. So, but okay. Also, I put some icons, car parts here. So it's like try to use this analogy. I can't think of any better way to describe this. It's like when our brain's stimulated by drugs or cues, any cues. It's like you insert a key and twist it to the ignition. So you start an engine. So then you pump the gas. Of course, sometimes you pump a lot, sometimes you don't pump a lot, right? But no matter what, your engine starts reacting, right? Of course, then the amygdala and the hippocampus is like your dashboard. So the dashboard, it registers the mileage. It also has GPS. It remembers the beautiful places we went last time. So that's very important, because next time it automatically, whenever I see something fun, so it's going to send messages to the VTA, ventral tegmental area, or even nucleus accumbens, or even prefrontal cortex to tell them to act, to use, to just impulsively, move on. So this is a reactive. I'm talking about reactive reward system. So this is automatic. Okay, there's no control here. Yeah. Next one. So now we move a little bit up, okay, to the prefrontal cortex. Yeah, next, please. So this is a reflective reward system. So this is top down. Okay, reactive is bottom up. So you get a stimulus, you react to a stimulus, you have the dopamine surge. You may, at this time, you tell, basically you have to communicate with the high control center, which is with the prefrontal cortex. Prefrontal cortex is mainly, we're talking about it for addiction purpose. The prefrontal cortex can be divided into 3 different kind of areas. Orbital frontal cortex, which is kind of regulated impulses. Okay, ventral medial prefrontal cortex is kind of related to our emotion control. And finally, dorsolateral prefrontal cortex is a very important part of our brain. This is the highest control center. It evaluates the situation. It analyzes, and finally integrates all the different kind of inputs and reaches a final conclusion or decision. Okay. In a normal brain, it works very well. It coordinates very well. So every part of the brain gets a vote. And of course, the dorsolateral prefrontal cortex has a final decision, right? And of course, the amygdala and the hippocampus also has neurons. It's glutamate neurons connected to this prefrontal cortex. So basically, we have an engine, we have a dashboard, but no matter what, you have a high control center to say yes or no. And the final decision depends on how I'm going to integrate all this kind of emotions, affect, and impulses, and the cognitive flexibility, all these kind of things. Now, this part of the brain takes a long time to build and develop. And this part of the brain is, is regulated or is influenced by a lot of things, including our developmental things, including we're talking about social dynamic, social supportive system, learning, education, even financial status, and all different kinds of things, right? Okay. So putting together, so we have top down and the bottom up. So the bottom up, which is basically reacts to whatever outside external stimuli. Sometimes it may not be external, maybe just internal cravings. Okay, with time going on, the internal cravings become a stimulus as well. Then we have top-down part, which is kind of high-level control. Okay, it says yes or no, and it gives green light or red light. Okay. So these two parts coordinate with each other, and they're interconnected. They're synchronized. They work together. They have to work together. But if they're disengaged, if they're disconnected, imagine that's what we call it, like brains hijacked by drugs. So what happens? Yes. So basically the prefrontal cortex has lost control, cannot give orders, cannot overrule in this kind of situation. Next slide, please. So temptation. So it's pretty simple. So temptation is basically you have drugs, paraphernalia, or internal cravings, whatever is, it stimulates the neuron, and the neurons start firing, sending a lot of messages, causing dopamine surge so high, and that's pleasant, pleasurable, right? And of course, the amygdala and the hippocampus bring back the memory. Okay, wow, that worked before, and that made me so happy, that gave me high, or whatever. So at this time, the impulses part of your brain, which is orbital frontal cortex, takes the vote. Okay, says go, please, I need to use. And it totally depends. So the willpower, if that person has willpower, then the dorsolateral prefrontal cortex part can take control. It analyzes the situation and can basically save the temporary gratification. And for the future, we're talking about long-term goal, right? If you have long-term, like goal-directed behavior or purpose, then that can override. So in that case, we do what is right. Unfortunately, a lot of times, if these two, talking about reflective and reactive parts, are kind of disengaged, then the brain lost control of the rewarding circuitry, the low-level rewarding circuitry. The dopamine surge is too high, and then amygdala is too activated. Then the impulsive action will be taken. So, yeah. Another thing which is very important in addiction behavior is the recruitment of stress pathway. So at the beginning, the stress pathway was just, we're talking about HPA axis, right? Hypothalamus, pituitary gland, and adrenal gland. This is our fight or flight system. This is our system. This is our body system, deals with all this kind of stress, dangerous situations. Okay, so at the beginning, they're recruited just to compensate. It's like you have two people fighting with each other. Okay, then the third person try to intervene, try to help, to calm them down and to pacify, to tell them, like, try to negotiate, try to negotiate. Okay, but with time going on, unfortunately, things got, not controlled, so out of control. So what happens is then extra hypothalamic CRF, corticotropin releasing factor, got increased so much to the point, basically stress pathway, stress circuitry got overactivated. Okay, the next slide, please. So this is how it works, how our two systems work with the long term of drug use. So at the beginning, when people started using drugs, it was impulsive. It was just getting some reward. Just try to feel good, okay? Feel high. So what happens is with drug exposure, yes, dopamine level increased. Opioid, we're talking about internal opioid system started activated, right? And the GABA system and the glutamate, all these kind of neurons, all this kind of involved in the circuitry become activated. The levels increased. Then when they stop using, okay, but still, this is we're talking about in this early phase, then remember the previous graph, basically the stress system got recruited. So you got a corticotropin releasing factor, and the norepinephrine, dynorphin, and the neuropeptide Y, all those kind of hormones got changed, right? The level changed because of this. But with long-term use, then the brain builds a tolerance. So the dopamine surge is not that much anymore. Okay, so here's a big difference. For a long time, we thought, comparing with normal control, the brain that is addicted to cocaine and methamphetamine or any drugs, they can have high magnitude of dopamine surge. But actually, it was found to be wrong. Comparing with normal control, after chronic use, the dopamine surge is less than normal control. So what can they do? Yes, when they're in active withdrawal, the dopamine level is way low. What can brain do? Apparently to recruit the stress system, the stress circuitry. So in that case, all those hormones involved in the HPA axis got a sky high and makes people distressed, anxious, depressed, hopeless, worthless, frustrated, whatever you can say, right? So a lot of times I tell my residents, I said, you think our patients are trying to use drugs to get high? At this stage, they're not. At this stage, they just try to get to feel normal. So it's negative reinforcement instead of positive reinforcement. At this time, every day when they get up, it's trying to feel normal. Because if they do not use, they feel miserable. So that's how it works. So that's how our neuron, our brain works with a long history of drug use. Yes, next please. So it is very important because when these two, we're talking about two parts of the complementary parts of our addiction rewarding circuitry got disengaged, then we need to treat. Now, how can we re-engage them? How can we reconnect these two parts together? So this way, the high-level control center can regain control, can give orders to tell us to stop, right? To resist the temptation. So I always tell patients, I said, well, your low level of brain now got hijacked by your high level brain got hijacked by drug. Now your low level brain kind of takes over the whole system now. So what can we do? We give you Suboxone, makes you feel better. We give you naltrexone. We give you medications to help you feel better. So this way, you do not have that kind of dopamine surge, that kind of decrease. We're talking about actually decrease the sensitivity or decrease the dopamine surge from nucleus accumbens, right? Because remember with time with chronic use, the nucleus accumbens become less sensitive now. So we try to resensitize your nucleus accumbens. So we use Suboxone to help you with your withdrawal, helps you with your amygdala part, which is kind of, because when you're in withdrawal, you have a lot of memories come back, right? Because you feel distressful, you feel miserable, right? Because the medicine can help you keep you from withdrawal and can make you feel better. However, that's not going to help you to regain control. That's not going to help your high-level control center to regain control. So what can we do? Yes, that's why we need a therapy, right? That's why we need meetings. That's why we need a group. That's why we need a peer support. We need to help each other, and we need a good supportive system. We need to utilize whatever supportive resources you can have. So that's how it works. So basically, giving you medicine only works on part of the brain, part of the addictions and rewarding circuitry. So the therapy is the key. The community behavioral therapy is the key. So I think it helps us educate patients. It helps us also understand, why the combination treatment is way more important. Because if patient only gets only gets Suboxone from a provider without doing anything else, and that won't work, right? Yeah. So here's the hope. So this is the same brain. Okay, we're talking about not same brain. This is the two brains. One is a healthy person. One is like a brain after methamphetamine use. Actually, this study recruited I think it's 20 patients, total 5 patients stayed for the whole study. So 1 month abstinence from methamphetamine, you see the brain activity brain activity kind of, changed back a little bit, right? Then now this is the striatum area. This is basically the basal ganglia area, which is kind of related to the rewarding, talking about the feelings of like pleasure and the reward, right? And this is the main part of the rewarding circuitry, right? Then after 14 months, you see brain activities, talking about the basal ganglia area, striatum area, the brain activity is kind of got much closer to healthy person control, right? Mm-hmm. So actually they did this study on 5 people and they all showed the same consistent result. So that means I always tell them, like I said, yes, your brain got rewired after 30 years of drug use. However, there's a hope. The hope is like, 1 month, 14 months, and even like we're talking about 1 year, 2 years, even 14 years of sobriety can probably rewire your brain and give you back your normal neurological functionality. So that's what I think. So I always think is like, even if it's a brain disease, but there's a lot of evidence showing like, yes, it's a treatable disease. So definitely, and it's something which definitely with time going on, people can regain brain functionality. They can have normal life. They can have jobs, they can have relationships back, they can have family, they can have their kids back. So that is hopeful. Yes. Thank you very much.
Thank you, Dr. Zhang. All right, guys, we have time for questions.
Yes, I have a quick question. This is Serafim Kashkalov. As I mentioned earlier, I'm a surgical PA, and I just have I guess 2 questions. First one is there a quantifiable number of X amount of, Percocet pills that you go from the positive to the negative reinforcement kind of scenario? That's my first question. And then the second question is, when we prescribe patients narcotics for post-operative use, I'm not sure exactly how many, pills I should prescribe to a patient. And that kind of ties into the first question. How many pills do we prescribe before, a patient could potentially be dependent on these narcotics?
Dr. Hirschler has any comment on this?
I guess my thoughts about when negative affect occurs after someone's exposed to an addictive substance like an opiate. We know that if you expose somebody to cocaine, they get an upregulation of dopamine, and then there's a counter-regulatory response where the prodynorphin gene is turned on, and dynorphin is the negative emotion neurotransmitter. So it's a homeostasis. Everything's always balancing. And so if you're creating euphoria, you're going to have a counter-regulatory negative affect, kind of like the cocaine crash. And so it doesn't take too many exposures of anything pleasurable to have a counter-regulatory response. So that's my answer to your first question. And then, of course, what happens is once somebody knows that they're relieved, but their negative emotion is relieved by something pleasurable, then you've created a monster because they're going to turn to that as a source of coping, to deal with negative emotion. And then how many pills to prescribe? That's a tricky question, because untreated pain status post-surgery is a big concern. But I think it depends. I don't know enough about surgery to know how much pain is related to a particular procedure. But I think there has been some kind of over-prescribing of analgesics, sort of with that 5th vital sign, and really looking at pain as something that has to be eliminated. And I'm more into functioning, I guess, and activity. And so if someone can be active and they're functioning well, then their requirements for analgesia are less. You follow me?
Yes. Thank you.
You're welcome.
I don't know. I can't make any comment because I do not have experience. I guess my practice is to take people off opioids and not giving them opioids. So I guess probably it's hard for me to give you any experience. But per study, yes, the duration, the amount of this drugs or pills, patient use definitely is kind of determining factor as well. But opioids is highly addictive. We're talking about it's highly reinforcing, and the negative reinforcement is pretty quick. So they say like 1 out of 6 cocaine users gets addicted. I don't know how many people, 1 out of how many. I believe it's very close. I think it's very close to 6 or 7. Yeah, opioid users or pain pill users gets addicted. I think something like that.
Wen-Hong, I was going to say one other thing about your talk. You know, the medial prefrontal cortex kind of squelches the negative emotion of the amygdala. And so through therapy, we train our medial prefrontal cortex to mood regulate and to counter negative emotion, which kind of reduces that whole cycle. Yes.
Yes, actually, they did similar. I think a couple of years ago, I read a study like they did image study after therapy. They also found some kind of brain activity change in the prefrontal cortex area. Yeah.
Hello, Leslie Sims. If I heard you correctly, you said that Suboxone resensitizes the nucleus accumbens. And therefore, they could return to a normal brain.
Well, I think this is my statement. I guess I do not have any scientific evidence to say that. However, I think that pharmacologically, Suboxone is a partial agonist. So it's not a full agonist. So comparing with methadone, oxy, Percocet, or whatever, hydrocodone, this kind of morphine, this kind of full immune receptor, full agonist, Suboxone does the downstream change is different. So this it's like people who are on antipsychotics and the dopamine talking about the dopamine receptor is kind of change with time going on. It's neuroprotective. So I would say probably generally speaking, taking a medicine like a Suboxone probably is neuroprotective. However, I do not have any studies to support my statement. On the other hand, Suboxone not only work, but buprenorphine not only works on mu receptors, it does work on kappa and delta receptors. And Dr. Hirschler has mentioned this many times. And those receptors are kind of very important in our talking about the emotions, kind of stress tolerance, and this kind of dysphoria, feelings. Yes, it can regulate and it helps.
Okay, so I'm guessing that different people respond differently and their brains recover differently, because we have someone who's been on Suboxone for 10 years, yet they still have those addictive traits that you see in addiction. Mm-hmm. And then we have some that have been on it for 6 months, and it seems like they never were an addict. So, it's different for everyone, I guess.
Yes, it's the same like any other medications for diabetes, for hypertension. Nowadays, it's pretty common practice to use a combination of all different kind of cocktails of antihypertensive medications. I guess no medicine works for everybody. Right? Otherwise, we just need one medicine. I guess all medications work on some people. Otherwise, FDA wouldn't approve it. So I also say I feel the same. I agree with you 100%. Because a lot of times our patients, when we have some patients who are on Suboxone for a long time, still struggle with methamphetamine and marijuana and all different kinds of things. So I guess. Yeah, it's kind of it's amazing. We don't know. They said only on this globe there are the thousands of chemicals, millions of chemicals, but they only like 250 chemicals can get people addicted to. So we still don't know neurobiologically why some people choose alcohol, why some people choose benzo, why some people choose, even if they share the same common pathway in the ventral tegmental area. Actually, they're interneurons. That can explain very well why opioids, stimulants, benzo, they're all finally share the same common pathway. However, we still don't understand why some people choose one of them or some of them, or this is, I guess there's still a long way to go.
Mhm.
I guess one thought that I have about people some people doing well with recovery and some people kind of being stuck in an addictive pattern is that you get good at what you practice. And so if people are practicing recovery-minded lifestyle, they get good at that. And if people are practicing negative behaviors and manipulation and the things that go along with addiction, that's what they get good at. And you kind of, that circuitry gets ingrained. And so it really gets down to what the person is practicing.
I think the most important thing, or the most obvious thing I can say for our 500 patients is the first, Suboxone has been used as a harm reduction medicine. It really helps them reduce harm. That's number one. Second is Suboxone has definitely increased their compliance. So the same time they get Suboxone from our clinic, they also receive the whole package. They receive therapy sessions. They talk to therapists. They attend meetings. They get a lot of social peer support. So those things definitely are way more important. So I think Suboxone is a wonderful medicine in terms of opioid use disorder patients. I hope there's a similar thing for methamphetamine users, right? So yeah.
Great. Thank you again. Thank you, Dr. Zhang.
Thank you very
I
much.
liked your car analogy, by the way. I thought it was perfect.
Thanks.
All right, guys. Do you guys have any final questions before we break? All right. Well, we'll see you back in 2 weeks. If you guys have any cases, of course, I'll send those reminders out. But you guys have a great day.
Bye-bye. Thank you.
Yes.
Thank you. Sorry, just a quick question. You said two weeks is the next meeting, and what the meeting is going to be about?
Give me one moment.
I cannot remember.
Yeah, for some reason I thought you guys said it's once a month, every first week.
It is the second and
Right,
fourth.
it's the second week. Yep.
Yep, so it's twice a month. It's the second and fourth Mondays.
Okay, got it. Perfect.
Yeah, we don't actually have a topic assigned for next week, so I'll send that out in the email, let everybody know.
All right, great. Thank you so much.
Thank you.
Thank you, Dr. Zhang.
Thank you very much.
That's good. Do you, that was interesting about that rat thing and the